So Dr. McKenna, can you hear me?
I can. Can you hear me okay?
I can. We can hear you fine. Well, we appreciate it. Why don't you go ahead and take over? We hear you fine. What we'll do, if it's okay with you, Dr. McKenna, is invite the people here to ask questions along the way. Certainly during the centrifugation process, there'll be a little bit of time that you can give a narrative on what you've done and maybe the pathology that you've seen and that kind of thing. So, having said that, we'll just turn it over to you.
All right. Medial face of the tibia. It's already been sterilely prepped. Again, we're going to do this just like we would an in-office draw. In-office draws are not as common in my practice as the operative theater, because in the operative theater we do every ACL, every total knee, and at this point pretty much every rotator cuff. In the clinic we do the follow-up OA injections and the follow-up microfracture patients, and some rarely primary injections in people that are just not real candidates for big invasive surgeries, and all the chronic tendonitis patients, lateral condylitis, Achilles tendonitis, all those patients are, again, those are all in-office draws. So this would be pretty much the way we're going to do an in-office draw. You don't need much of a sterile field. You do need to have a sterile table prepared. So the back table we've already prepared the lidocaine with epinephrine for our periosteal anesthetic. We've already prepared the 5 cc's of lidocaine in a syringe to inject Randy's joint capsule and the incision in the back before I put the needle into the intra-articular portion of the posterior aspect of his shoulder. Again, Randy has an MRI that shows some decent glenohumeral arthrosis, a little medial arch stenosis in the shoulder with some rotator cuff tendonitis. Without a partial thickness tear and dramatic tendonitis, my primary therapy for Randy is just going to be an intra-articular injection. In the clinic, with a partial thickness tear in the cuff and someone that doesn't, or isn't a medical candidate or is not ready for operative intervention, under ultrasound visualization, we'll actually inject the rotator cuff attachment. But again, it's a little bit more of a setup from an ultrasonic standpoint. And with Randy's condition being primary glenohumeral changes, we're just going to do an intra-articular injection from a posterior approach. So the tibia is draped off. I'll just relax as much as you can, Randy. I got my left hand on the fibular head, the finger on the tubercle, and my medial face pretty well prepped out. Because we don't have disposable scapulas or a big orthopedic tray here, we have a 15 blade on pickups. So the non-injecting tray. So we're going to put the medial face. We're going below the tubercle on the flat portion of the tibia, a little stick. Okay. So that's the medial face. We go down to the periosteal layer. I'm going to inject. See the skin wheel a little bit. Move the needle again down to the periosteum. Inject, and you have to pull it away a little bit. Periosteal sleeve is tight. Inject. You can feel the kind of skin wheel that you create. Inject, going to pull away. Again, we want to just pepper that periosteal sleeve, and there we go. It's important, and because we use a needle with epinephrine, sometimes you'll lose your poke hole. Little point of view is that you want to make sure that you've isolated and know the area that you just provided the subcutaneous wheel of block in. So because with epi, sometimes you'll even lose your poke hole. I've still got my poke hole isolated right there in the skin. That little poke hole where the needle is right where I want to make my incision, because the skin's fairly well numbed up there, and the periosteal sleeve will be numbed up there. So we're going to let that set for a few minutes. Again, it's 1% lidocaine that we used with epinephrine, so it sets up a lot faster than a Marcaine block would. If I'm going to do someone that has a long drive ahead of them. If I'm going to do someone that flew in from out of town and is flying out that day, I'll use Marcaine on the periosteal block because it provides a much longer time of action as a subperiosteal block. People really, by the time the block wears off, literally pretty much have no tibial spine pain. All right. It's been a few minutes. I'm turning the leg in a little bit so I can fit my fingers on the fibular head. Make it where I can actually reach my drill. Fingers on the fibular head, move that over. Again, in the OR, it's easy because everything's prepped within your sterile field. And move this, make a little poke hole in the skin. And again, the reason that's important is because we see decreased platelet cell activation with the making of an incision. In someone that's, especially an iliac crest draw, I'll actually even take a hemostat, go through that incision and just kind of clear up a little bit of the crest so I know I have a good stable field. The key with the tip of the insertion cannula that created the way it is it won't walk away from where you put it. But I don't put it on the drill first. I'll put it on the bone, find my home, and then use the drill to insert it. So I'll literally put the cannula through the hole. Pulling that skin over onto the bone. You okay with that, Randy?
Yeah.
Turn the leg, move the hole. Okay, and again, as you feel it start to go through the cortex, so when you advance that, so see a little marrow come through the trocar. You feel that?
I feel
Not comfortable, right? But as we pass off the injection, I'm going to hand this to her. Now it's just about what's in the vacutator. A little bit uncomfortable when you start to feel the marrow.
I can feel it. It's not so bad.
Tolerated, right? This is the worst part. I mean, all the bad parts over. So, usually with the patient, if you just let them know the hard part's done, a little bit easier to tolerate.
Do you want to address the pressure you're putting against that?
Yeah, the key, you don't want to grab a hold of the syringe and just pull back. You may dislodge the catheter. You want to make sure you put your fingers on the syringe and pull against it. I don't, even though it's a self-locking syringe, I don't just pull it all the way out and lock it, because when you do that, it's a violent draw. It increases the turbidity of the draw and will decrease your cell count. So I will twist it around a little bit sometimes as I start to touching the hub of that. So.
When do you want us to show now what the Alexis is doing, or is they only
Alexis is actually beginning the process of filtering the blood, the bone marrow.
Question? You're absolutely spellbound, Dr. McKenna.
The filtration, the new filter makes this a lot easier. The old filter, when we first started doing this, it's a 200 micron filter, which is basically an 18 gauge needle, but we would see there was a lot of cord and it was cumbersome. The newer filter makes it a significant difference. So, bone marrow's out. I will close this little. Again, it's just a little poke hole, but trying to sew Randy's hair.
So you're spinning 32 cc's. How many do you want that?
Let's get 4. All right.
What's the speed of the machine?
I can answer that if you want me to.
Yeah, he would only his.
It's
20
triple.
It's 2800 on the slow, which is separation of packed red blood cells, and then it goes to 3800 for the fast.
So, did you hear that? It's 2800 on the slow, and then it goes to,
And then it goes to 1000 to pull off the packed red blood cells, and then it goes to 3800.
yeah, then 1000. The key is it's a triple phase spin, right? So it's 2800 on the slow, then it goes down to 1000 to pull the packed red blood cells, and then it goes back to 3800 to complete the centrifugation and help create your buffy coat. So the key is it's not a one-phase spin, which doesn't adequately separate out the red cell volume and create your buffy coat. So it's the three-phase spin of the machine that's one of the big differences. And I'll go through the differences real quick on the different machines, because I think with our experience over the last 8 years, I can provide a little bit of a unique perspective on the different machines, because we've used all of them. We started out with GPS just because it was the first. GPS, the cell counts are not great. And actually, out of the 4 real centrifuges, and I won't include RFX's APC in that because it's not even really PRP. And now they really don't even claim it to be PRP. But the GPS machine does a decent job with the separation for PRP. It doesn't have a buffy coat. It doesn't yield you cell counts high enough with your bone marrow to make it a choice for me prior to us working with arterioside with the biospin. Then we went to Harvest. There are several huge advantages to Harvest over the GPS machine in that we were able to get much higher cell counts and we could spin a higher volume. The significant downside to Harvest is it's not an automated draw. So when you draw the buffy coat off to give you your product, that end product that we're going to inject to the patient, depending on who was drawing the buffy coat off, what nurse in the OR or the physician or an engineer from Harvest with the pew that actually came out and drew for us for a while, you could actually, your cell counts would be very non-reproducible. In other words, you would see huge peaks and valleys in your cell count. One cell count would be great, the next cell count would be mediocre, the next cell count would be okay. and that was because it was not an automated draw. Some people were really good at getting the Buffy coat, some people were not so good at getting the Buffy coat. And so there was too much variability to get a dependable draw. So if you want to do something and get the same result every time, you need to develop a system that gives you the same product every time, and that was very difficult with Harvest. Then we went to,
you want to show the second post.
yeah, so then you turn it to the machine. The machine now is going to that second draw where it's starting to pull off the red
So
cells.
this is the.
And you can see the red cell syringe start to fill up. So the next machine was Angel. Angel was great, real high volumes of cells to spin, really decent cell counts, reproducible with the Harvest machine, but because of the collection tubes as a bag, when you look at the seams of that bag, a lot of our cells were in the seams, and if you know how stem cell behaves and that adherent nature of the cell, it hides in the seams and creates clots. So when you started doing analysis of what was in the clots and the seams of our bag, that's where a lot of our cells were. So even though we're getting decent counts, we weren't getting a very efficient collection system and separation. But it was okay. The arteriocyte is unique on several instances because it gives us equivalent cell counts to what we were getting with our best of the Harvest draws, equivalent cell counts to what we were getting with our best of the Angel draws. It lacked the inter and intra observer variability because it's an all automated draw. So it's a significant advantage as the machine with laser line measurements picks your Buffy coat and gives it to you. It also allows you, unlike the Angel machine, to determine your volume of substrate. So with the Angel, you can't set how much you want to give back to the patient. So what would happen is you would get 80 or 90 or 100 cc draw or 40 cc draw, and it didn't matter. The machine was deciding what your volume was going to be. So sometimes you go through all this trouble and it would yield you a half to 1 cc of injectable substance. And if you're an awake patient in that setting, it's a little disconcerting to see all this trouble for 1 cc. As a surgeon, especially if you're using it in a big defect, an osteochondral lesion or a fracture, to not know how much you're going to have to mix with your graft is disconcerting. And the arteriocyte machine with the BioSpin that Biologic Therapies is now licensed gets rid of the disadvantages and maintains the advantages of a cylindrical canister. You can do 3 spins with the same kit. You don't get the seams and lose your cells. You have an automated draw of your Buffy coat. So if you compare it to all the different machines that we've used over the last 10 years now, there's a reason that we have kind of evolved into the centrifuge that we use now. All those other machines you can make a good case for, but certainly especially in the beginning when you're doing cell counts on everything, there's just too much variability with Harvest. There was too much that I knew I was losing in the seams after we analyzed that with the Angel. And the big disadvantage with the Angel is you didn't know how much you were going to get to inject at the end. And with the GPS, the cell counts are just not even close to the others. So Angel, Harvest, arteriocyte, really the only 3 machines that yield an appreciable cell count. Angel and arteriocyte, the only machines that give you an automated draw, and so lack of variability in your cell count. And now arteriocyte is the only machine that you knew exactly how much substrate you were going to get because you can program the machine to deliver you the volume that you want. So it's just an evolution of thought along the way. Steve, is there any other questions about the machine itself?
Question? Yes, we have a question, Dr. McKenna. Mike over here.
Dr. McKenna, how do you know how many cc's you will need? How do you decide on this?
Well, in this patient it's easy because he has primary osteoarthritic changes in the anterior capsule of the shoulder. Physiologic volume of the shoulder is between 4 and 8 cc's. Since I haven't scoped him and I'm not going to wash him out, All I'm going to do is inject the shoulder itself, and non-painful injection. When you get above volumes of about 10 cc's, you start to get a significant amount more pain in an awake patient. I will do that in a sleep patient because I'll inject the cuff, and I'll inject the capsule, and I'll inject my portals. So in a sleep patient, I'll actually take the PPP, inject my portals. I'll take the PRP, the bone marrow aspiration portion of the part with the cells. Okay. So now the machine's collecting. Now we turn to the machine. I get about 4. If I program it for 4 cc's, I know it's going to be a good quality aspirate based on the fact that we only got about a 50 cc drop. If I'm using it for, the big question is there ever a point at which you're going to have too much? And the answer is no. But when I will want a lot is if I'm doing, and I talked to one of the attendees earlier about when we inject the paravertebral muscles in the lumbar spine with multifidus dysfunction syndrome, you just get this dead muscle mass in a post-op patient. I'll inject 3 to 5 cc's per level of the dysfunction, and usually it's 1 to 2 levels. And I want at least 3 cc's a level, so I usually have to do 2 spins to do that. In a big non-union or a spine fusion, you may have to do 3 spins, and you want about 5 cc's per level to add to your graft. And I'll tell you that depending on what substrate of graft you're using, depends on how much bone marrow you want. I use NovaBone a lot as a synthetic because there's a very low glycerin, and glycerin's cytotoxic to the mesenchymal cell. So if you use a real high glycerin-based graft, you're not really doing anything, your cells are disappearing. And NovaBone has a very low glycerin, and I think it maintains cellular viability better. But if I use 1 cc to about 3 to 5 cc's of graft, because if it's too dilute, it just turns into soup and you can't control where it goes. If I'm using autograft or allograft cancellous, then I'll add a little bit more per cc of bone, almost a 1-to-1. Is that our substrate?
Yes.
Okay, hold on.
So will you explain that? I just wanted to show that there's PRP and this is PPP, but we're not using it, but just to show that's
Okay, so
it's Buffy coat and then
what Alexis is saying is that our Buffy coat solution is in the left syringe, the PPP is in the right syringe.
So we're not using the PPP today, but I just wanted to demonstrate that that's how you obtain it. Or that's where
it is. All right. You want to help up here?
Yeah.
What is in the right line, please? Say it again.
The platelet pore fraction.
Okay.
Don't put the camera on Randy yet. We're going to take a shot.
So I'm going to go ahead and just cap this off. Wait till you're ready.
Dr. McKenna, you may want to, someone in the audience may have a question about why is PRP red and what's the significance of having it with a little bit of redness to it versus like an ACP that would be light yellow.
Okay.
We get it ready. Getting ready, so.
Okay. What Brian is talking about is some people may ask, why is the PP portion of our substrate, you're talking about the PRP portion?
The PRP, yeah.
The PRP portion of our injection. We're calling it PRP, but we're not using PRP, we're using BMA, right? Bone marrow aspirate concentrate, so BMAC. Why the bone marrow aspirate concentrate portion of what we're giving is a little red instead of straw or clear color. And the reason before that is because that's where our hemopoietic stem cell collection is too. So you see the difference in the platelet plasma on the right, the PPP, which we'd be using as fibrinogen in our portals and our closure, and the BMAC on the left, which has our stem cell concentration, our hemopoietic stem cell concentration, and all of our growth factors that would be associated with the normal PRP collection. So even if we were doing a whole blood spin, it would look exactly the same.
And it's about 6 to 9% crit, if someone's interested in that.
69%?
6 to 9.
6 to 9, sorry.
Yes.
And the creatinine, well, so the creatinine of our BMA is somewhere between 6 to 9%. 6 to 9%. The problem, how hard, that's another downside of the Harvest side. The way Harvest cheats and get cell count equivalent to the biospin is they elevate the crit to like 13. And if you have a crit somewhere between 12 or 13, you're kind of cheating a little bit to give you some of the noise of the cellular activity, and so they can artificially kind of increase their cell counts.
30 actually, that's
Yeah.
reported in the literature.
Yeah, actually, Brian said that sometimes the harvest machine can get your crit up to 30, and at that point, your cell counts really, it's not a comparable draw to what we just did with the crit of 6 to 9%. We've actually controlled and limited a lot of the what we used to refer to as just noise from the red cell. All right, so in a posterior approach to the shoulder, you're just gonna let your arm hang down. Important landmarks, I always tell people all the time, anterior lateral aspect of the acromion, and then you just find the coracoid. If you find the coracoid with 2 fingers right there, put your thumb in the back, and I'm gonna have Alexis kind of pull down on his arm over here for me in a second, and sit up straight as you can. And then all I do is in my posterior approach, the weak spot of the shoulder is just go to the coracoid. And as long as you can isolate the coracoid, you find the weak spot of the posterior approach, injecting the shoulder from a posterior approach is pretty easy. If we're doing a rotator cuff injection, I go direct lateral, elbow in and across, and I'll have the ultrasound from either the front or the back, depending on where the biggest tendinotic area is in the cuff. You uncover the cuff by bringing the elbow down and either extend the arm or flex the arm, and I'll get in the back portion of that tendinous portion or the front. Since this isn't a cuff injection, I'm just going to bring it up straight as you can, and then we'll externally rotate the arm, find the coracoid, and just inject towards the coracoid. I'm going to put a pair of gloves on. So what I'll do is I'll have them squirt the bone rasper concentrate from my cup. All right. So pull the substrate up again in the interest of creating as little of a platelet cell activation as possible. We'll draw that up with an 18 gauge needle. So I'll take a 22 gauge needle just into the skin, little poke hole. Inject. I won't add the epi to our cells. Some of the chondrolysis literature will tell you why. But I still have my fingers isolated on the coracoid. That's about the worst part. Let the lidocaine sit up in the skin for a second. Again, I didn't put any epi into the joint. I think it's important to avoid epinephrine into the joint in the presence of bone marrow aspirate concentrate. Let the elbow hang just about right there. Kind of pull down on the arm a little bit. There you go. All right. It's about the worst part right there. All right, right towards the coracoid. Up through the joint capsule. Is that too bad?
No, it's good.
Yeah, a couple little things. I think, and again, we talked, it's way easier to ruin your cell count than you think. And a couple of little things that you do along the way can help a lot or hurt you a lot. Using an 18 gauge needle for the injection makes a huge difference. There's a reason that filter isn't smaller than 200 microns because you don't want to lose all your cells. An 18 gauge needle helps prevent a lot of the platelet cell activation. Platelet cell activation drops your cell count. So everything we do along the way, from the formation of the little incision during the draw, from not using epi as part of our solution for the injection, to using an 18 gauge needle for the actual injection of the stem cells, to not putting epinephrine within our stem cell in the same shot. All that is done to avoid platelet cell activation and drop our cell count. So the goal is, if you're gonna go through all the effort to give a patient a stem cell injection, give them the best quality injection that you're able to administer. And it's not that much harder to just pay attention to the little steps. And we've done a lot for you to do that. From the kit we have to provide you with biologic therapies is a lot of effort has gone into making sure that we try to help you get the best result possible with the training aspect that we work so hard on, with some of the teaching videos and the presentations and the site visits, and certainly with our OR in Texas being a pretty much open door policy for visitors who want to come watch the way we do it in Texas. Usually on Monday we'll do somewhere between 8 and 12 surgeries. Wednesdays somewhere between 8 and 12 surgeries, and about half of those cases usually will involve stem cells. So if that gets to the point where someone wants to see our rotator cuff techniques, our ACL techniques, anything like that, we also have our OR is a significant visually equipped as far as I have an arthroscopic camera, a Google Glass camera, an exterior room camera, and a light handle camera that all go to one screen as a 4-split screen. And as long as we know about it ahead of time enough, we can usually set it up to where you can actually do a teleconference where you can still ask or text questions in and actually watch the surgery and see all of the views necessary. I think it's unfair when you do a teaching surgery or a webinar and you're only looking at the arthroscopic pictures, or you're only looking at an external camera, because you can't really see what we're treating. And with what we have available for us now, I think we've kind of passed most of those hurdles that we should be pretty easily solved over the next month or two too.
Can I get up? Am I done?
You're done?
Yeah.
Is that all right?
Very good.
That's all I did.
You think?
You'll be good.
All right. Well, look, here's the deal. What I tell people about in-office crest injections: if I can squeeze your crest and you're not ticklish and it doesn't hurt, this isn't that big a deal. If we can't, there's no reason to push the envelope. Don't touch that part. There's no reason to push the envelope on that part. If you can't do it that way, then you move and do it from the tibia.
Why don't you the audience take a 5-minute
Yeah.
break while you just prep?
Great. So while we prep, I'm going to get Jason. We're going to figure out whether we're doing a crest or a tibia, and once we get that figured out, we'll come back and answer any questions you have and get started on the second draw. Okay, just prep off the field. Again, the most important part is I'm going to make my skin incision in a different plane. And I won't take the tape off of this drape every time because I want a little freedom of motion sometimes. It's perfect. So now I'm up to that injection site. Again, anterior iliac crest, and I tell people just take your fingers, follow the ASIS, anterior superior iliac spine. You want to go just proximal to that. I'll lay my finger down and go to the first knuckle usually. So you pull that skin out of the way. little poke hole. So we're going to inject the skin and the crest. Still letting the local set up a little bit. You can see that my poke hole for my draw is significantly away from where I'm going to move that to. But that's where I've numbed the skin up, and I've numbed the bone up in a skin wheel underneath. So I'll move that back over, and that's where I'll make my poke hole, and that's where I'll draw my marrow from. We use, and this is an important point, because I think that in an in-office setting, you're not a lot of people out there are going to have a sterile drill. You don't have to have a sterile drill. You just have to be careful what you do with your right hand holding on to the drill. The catheter tip, the catheter is important to maintain sterility. Use your left hand, use your right hand with the drill. As long as you are able to sterilely, as long as you maintain the sterility of the catheter and pull out that trocar, then you haven't violated. It's just like giving an in-office injection. You don't use a sterile syringe for every in-office injection. You use a sterile needle and not a sterile syringe. So, and you're usually drawing those syringes up non-sterilely, and honestly, most people in their office don't even use sterile gloves to do an in-office injection. You use office gloves, but you prep the field and you don't touch the needle. It's the same way with doing a bone marrow draw. You prep the field and you don't touch the needle. All right, so we're going to go ahead and start.
Can you feel that?
So I'm going to move here. Feel that too much? A little pressure. Okay. Rest is easy. This is where in the office we found it's really helpful to give patients headphones.
You can see how much easier it's going in versus
Yeah, you can see how much, Alexis brought the point, I'm sorry, how much easier the tibia draw, the iliac crest draw is to advance the draw than the tibia draw was.
That's great.
You know, what I'm going to do, I'll show you guys draw on this marrow without even taking the, see a lot of air bubbles at first. This without even using the plunger. Wasn't too bad, right?
It's all right. It's great.
I was just saying, you don't need that.
Yeah.
How do you? And honestly, this worked out perfect on who had the iliac crest draw, because Jason has pretty advanced glenohumeral joint disease from multiple dislocations. He had, he's an old baseball player, right?
Yes.
And had multiple dislocations. He's had and we all know the history of this, and I'm going to frack this area with the little catheter now. He had a capsular procedure where they took a shrinkage probe, which very short time in orthopedic history, with a laser, which we know what that did to the blood supply of the anterior capsule. See how much easier that draws now after you frack that zone. It's why we designed. So people always ask, why do you have the plunger? Well, because sometimes you need it. And moving that plunger down into that area, you can see how much easier that made that draw. And literally the bone marrow now will just continue to bubble up out of there, where before I did the plunger, it was a pretty difficult draw. And now you see after the plunger and get rid of some of that debris, just not as much butane needed to take care of your bone marrow. So I think actually iliac crest draws are faster, easier. You just have to have the right patient. It's a little bit more scary for the patient. A lot more scary usually for the surgeon, but it doesn't need to be. We created this catheter, so now I'm full. I got an easy 60 cc draw. I will not touch the hub of that needle because I'm just gonna withdraw the whole thing. Unscrew this, and my syringe on. There you go. So it's easier to tolerate. It's quicker to do. The key is isolating, and I think that if you get in your mind, you have to grab that anterior crest with your fingers on the inside border, and you want to just shoot the pen between your fingers. If you get your pins just a little bit of a grip, it's much easier to do. If a patient, the limiting factors for this, if a patient's not in very good physical shape as far as the size of their abdomen, you have to kind of...
The filter, how it says, like with the iliac crest draw.
Sure.
So there's zero.
Yeah, so here's the difference in an iliac crest draw and a tibia draw.
Nothing.
In the tibia draw, we lost about 10 cc's of 5 cc's or 10 cc's.
No, it's like fat.
Oh, fat. Yeah, we lost about 5 or 10 cc's of our fat from the marrow component. And in the iliac crest draw, it's not a fatty draw. We don't have a lot of bone marrow, but we didn't lose any of our concentrate. So it's just a better draw from a quality perspective. It's just not always the easiest draw, and it's not prepped into your field.
How many cc's do you want back? 4 again?
Even 4.
So this draw and this spin is going to be longer because we have 4 cc's.
Yeah. Because of the amount of blood we obtained, which is, again, a pretty easy 60 cc draw. It'll take a little bit longer to spin, to process.
And also you can see the difference in his blood is darker than Randy's blood was. So there is variation in the two.
Yeah, great.
Any questions so far?
So again, this POCAL, if you look where my iliac crest entry portal is way over here. The skin portal's here. So you just don't get that. I mean, you don't get seepage, leakage. It's a little thing, but not if you develop a synovial tract or you get a big leaky wound. But so what I was saying is the best thing about doing iliac crest draw on Jason is he has a fairly advanced humeral arthrosis. He's actually a scope patient when we get back to the States, probably. Based on the fact that he has some intra-articular debris, he has a labral tear and the front of his shoulder. He has some subchondral sclerotic changes on MRI and some chondral deformity and grade 3 to 4 areas of grade 3 to 4 chondromalacial changes in his shoulder with a Bankart lesion from multiple dislocations. So if someone of the two needed the best quality marrow today, it's definitely Jason. So in actuality, it's going to be nice to see, because we're trying to push Jason's arthroscopy back until we have the amniotic product available for injection into his shoulder. Patients with advanced glenohumeral changes, or patients with, I think that I'm looking for anything else I can add to the joint and bone marrow. That collagen matrix that we have available, especially with the anterior portion of his cuff that needs fixed, our little collagen patch with the cellular activity and the significant metabolic activity we've been able to maintain in that patch, I think is going to be crucial to see if we can get Jason over the hump in a very minimally invasive fashion without talking about humeral head resurfacing anytime soon, hopefully. A couple important things. Number one, when we focus the camera over on the machine, you see there's a pretty dramatic difference sometimes in the way substrate looks patient to patient. It doesn't mean anything's wrong. It's just some people have more of the different type of irons in their blood system than others, or the higher crit. But if you look at Jason's PPP, it looks darker than Randy's BMA did. And that doesn't mean anything's wrong with it. It just means that it's the difference, the genetic variability in his tissue. But it's an important little point to know, so you don't think that you've done something wrong. All right, here's a point I want to make. When we were talking about this in the room, everyone just saw basically the equivalent of an in-office draw from an anterior crest draw. And we were talking about the physics, because Jason said, it really didn't hurt. And he asked why, because if you go to YouTube, I challenge you to do this, go to YouTube and watch all the iliac crest draws out there with a jam sheety and a mallet. And I challenge you to do an in-office draw in an awake patient with anything other than the BMAC. And if the physiologies think of the physics of the pain of the iliac crest, the nerves crossing over the top of that crest, you can block in one little core area, because again, with the BMAC, you're putting pressure in one spot, right? A 15 gauge spot of pressure, and maybe a little surrounding pressure. With the jam sheety or a mallet, at the time of impaction, that spread of that impact is across the whole crest. So unless I wanted to selectively block the entire crest of the patient, there's really no way to tolerate an impacted, Peter, can you hold his arm for me in front? There's really no way to tolerate a jam sheety being malleted into your crest in an awake patient. Sit up as straight as you can for me. And we'll let Peter kind of pull down on your elbow. There you go. And just push him back towards me just a little. There you go, perfect. Look away there. Look at the other side. There you go. That'll help me a lot with your shoulder. Okay. So I'm going to find your coracoid, which is easy. The weak spot of your shoulder. So you have my
Yes.
Okay, so coracoid, posterior aspect of the shoulder, just kind of get up as far as you can, kind of let your shoulders kind of extend your shoulder, like push your chest out a little bit. There you go, perfect. All right, now relax. I'm going to inject the skin a little bit right here. And again, the reason we just inject the skin, I know every surgeon is used to just going right down to the joint. The reason I inject the skin a little bit is because I'm getting ready to put an 18 gauge needle in there. I'm going to let that set up just a little. Anyone have any questions about the if there's any questions about physiologically and from the physics perspective, how you would block the entire crest with 1% lidocaine away from? Actually, what Jason said is he don't think he could let me just hit it with a mallet. And my response was, I think if you take a nail and try to drive it through bone with the mallet, the impact every time would probably not have made you very happy with me. And with the drill, the insertion in the crest is actually much easier than the tibia face. You still have to have the right patient. They have to tolerate you being able to squeeze the crest. You have to make sure you bump up the hip. But in a sleep patient, and again, if it doesn't hurt to do it while you're awake, what do you think is post-op pain is really going to be from that too, right? The post-op pain from a mallet and microfractures around your entry portal into the crest is dramatic. Those patients hurt, and they hurt for quite a while. And if they get a subperiosteal hematoma, they can hurt for months. And we actually saw subperiosteal hematoma in some patients 6 months down the road that were still having a little crest pain and tenderness. And I have yet to find anyone that I couldn't percuss their crest when I took their dressings off of their surgical one. So, I mean, you take that for what you want, but we are writing up the cross-sectional analysis on the portals through pig bone that we did with our catheter and with the Jamshidi. With the Jamshidi, when you do cross-sectional analysis under a high-power field, it looks like a bomb went off. It looks like something exploded in that hole. And with the catheter, it's just a nice round entry portal. And I would call it an entry portal rather than a blast injury that you get with the Jamshidi. All right. So, still going right through his previous scar from his previous surgery there, right into the posterior capsule. We have a question, Steve? Here we go.
Any questions? I think they're waiting for you to get back up here, Doctor.
All right, cool.
It's going to bombard you.
Well, we're done. So, so the patient that actually has the most dramatic glenohumeral arthrosis actually got the best cells, and that
They
makes
also, we've taken a vote here, he has a much better tattoo than Randy.
me.